welcome to our journal club, which is being recorded live thanks to Dr. Yash Shah and our residents. So today we're going to present the article on child health disparities. What can a clinician do? And this was taken from Pediatrics Journal in November 2015. And it's really very salient to the work we do today because, especially in the community we work in, it's how we treat patients and how we understand their background, their culture, how sensitive we are. And once this article is presented by Dr. Arnauld and Rapheisha, I will add a few things to it from another article in this journal, in this volume, which is also very, very salient for what we do. So, Arnauld, you start. Thank you.
Good afternoon. My name is Dr. Oreste.
Just loudly.
So my name is Dr. Oreste. We're going to discuss about this article today. So the first thing, nowadays what happened with the primary care or specialty, we have more things to do nowadays, and we have more regulation, and we have also more needs for the family than in the past. But in the other hand also, what happened for the other hand, on the other hand, what happened, the needs for patients has changed also in the now. We have more diverse population. We have also the more stress that going on the family, and also we have disparities are still there. They have been there, they're still there. They have the race is there, ethnicity is there, socioeconomic status is still difficult. So the question that we're asking today, how can clinicians, as we are today, continue their dedicated services to children and ensure health equity in the face of these changes? So before going forward, so we can tell you what's the difference between health inequality and health inequity. It's very important to see the difference. Health inequality refers to individual or population. You have some factor that is non-controllable. That means you have a genetic disease in the population. You can't do anything against the genetics. This population will keep having this problem. This is inequality. But when you talk about inequity, this is very different. It refers to inequality that we thought can be unfair, unjust, but we can avoid them. Like, let's say we have a population that has a problem to have medication. They have the disease, but the problem they don't have money to get those medications. We can do something for that. This is what we call inequity in the healthcare system. So in this article, what happened when you have those disparity, they go by race, they go by ethnicity, they go by socioeconomic status. So children of color has this problem. Whether you're black or Spanish, you have all this problem. You can't keep up with this inequity. And what will happen? Those problems you have when you're a child. As a child, what happens when you go adult, it will stay with you. You're a kid, you're eating too much, you get diabetes when you're a child. When you become adult, you still have the diabetes will be with you. So we have to take care of this problem at the beginning now. So what happened next? The next, as a clinician, we can play a good role in the situation. So we can provide the opportunity, we can address those problems for this population when we see them as a child, not when they become adults. This is our role as a clinician in the health inequity. So they talk about this also that we call the culturally competent care. What does that mean for us is the ability for the healthcare systems that to demonstrate the cultural competence of a patient with diverse values, diverse belief, and diverse behavior. We come from everywhere here in US. You are black, you are from Haiti, you are from anywhere. When you come here, we come with our belief, our way to eat. And so all those, we have to take care of that. We don't speak English, we don't understand. All those are inequity for us when you come here. So the culturally competent care system will help you to handle those kind of problems. You have disparity in healthcare. So if you come to the hospital, you don't speak English, and you have to, they don't explain to how to do an MRI, you don't know. So the healthcare disparity become a quality of problems. So we have to try to improve this. And by doing quality improvement project, we can improve the situation. So where can you do this difference? Every day we see patients at the clinic, we see them everywhere. So at the clinic, a primary care physician can start doing this difference. When you see the kid, you can start with that at the clinic. And also, you can, when you see the patient, you see with the mother or the father. The family also is a, when you come at the clinic, is a way you can start doing this, making this difference with those kids when you see them. And finally, they have that they call the PCMH, the patient-centered medical home. So the patient is here, not only the patient come for diarrhea, you take care of the diarrhea, no, you take care of the diarrhea and what is behind those diarrhea. This is what we call all the system that is around. We'll talk about that in the other. So we have also what we call the class, culturally and linguistically appropriate services. This organization, what they have some principles they establish, and you can use to help this population. So they have some standard that help all the population, all the organization to use and to give the equal number of health care to everyone. The class we use has many standards. You can go and read them, and they have good information about what you can do to help the population. So, next. So this article, they outline the specific, practical, actionable, and evidence-based activity that help clinicians to assess one part and address health disparities related to race, ethnicity. So in the past, we're all talking about the community. This is since 40s. They talk about community-oriented primary care. After that, the Folsom Commission report, health is a community affair. So they said it's not only the kid coming to you, but it's how the kid is with you and all the community around this kid you're seeing all the time. And then class standards has some regular assessment of community. So in this article, they took some points. The first point, the point is the diagnosed disparities in one's community and practice. So what does that mean? We have the class have some standards, and the standards they tell you what you have to do when you have a patient with you. The patient is not coming to you just for diarrhea. It's not true. The patient is not coming to you because of abdominal pain. That's it. The patient is not coming to you because the patient can sleep. There's something around this. So you have to know what happened to the community that the patient has all those problems. So you have to assess your community, and after assessing your community, you can do what you have for this patient. So there's many ways to assess your community. What they said, the first thing you have the website. There are many websites you can access what happened in the city, in the district, the county, the state, and national data. You can also have some maps of child and family that help you to know exactly what happened for this kid. So when you go to those websites, you will see the person coming from Haiti, living with Haitian people. So what happened when this Haitian? I'm Haitian, so I'm talking about Haiti. But you can call it from India, to the same thing. You can know what happened around this culture of people coming from India. So you can go on the website, and you have all this information about those people. So you have to know your patient. So you have all those websites you can go, we can send them to you by email, and you can go and check the statistics about this population. How many kids are in the family? How many persons live with those persons? What are their habits? What their food, what they're eating? Everything you can know, everything about those population. How much money? Who is working? Who is not working? All those problems you can have access to those information, and with that you can help those population better.
Is this the same as the community health profiles that we showed last time, or this is by zip code that you can find out?
No, I don't have this. You just have to open the website and you go to look for the information.
Because we have to find by our zip code. Like suppose it's Brownsville, East New York. Last time we did a journal club with the community resident. I don't know which one it was. Arnauld, and we did the health community profile. So we have the profiles for each zip code. Actually, each center. So we have those, and we have it for Brownsville, and they tell you the poverty level and the health status. So that's another thing which we already have that resource. So I don't know if this is by zip code, but you can let us know.
I don't know exactly the right zip code by this one. But the only thing they said, you have to know this community before you give them your support unit.
It looks like there's more information in there.
They have
terms of
more
the food
information.
and the ones that they usually do as the zip code, it's more health related.
So this is
And the
important.
poverty level also
Right.
that is in there, but I think they may have other different information in
Yeah.
terms of foods and culture.
And the accessibilities and all
Yeah,
that.
I'm going to look into
Let's
that.
look into that.
Yeah.
Maybe during your rotation. He's laughing.
In terms of
Like a hurry up.
enough so in terms of the in terms in most of the more you always look for the population first. After the population also, you can, those information you have, the insurance can help you too. The hospital will be very know how to help this population. If they come to you, they don't have money, how can you help it? You have to know the medical, everything. All this information also, you have to know them. The insurance station, the research, the language, the SES of the patient, and then all those information, they said it, I didn't read the Affordable Care Act, but you have all those information, they use that to improve the healthcare system here actually in the US. So most of them, what happened so you have to know those. When you know those problems, so you can do more projects, some quality improvement that you can improve the care you're giving to this. So they said when you know this patient, when you know why they're living in the house, in the community, you can give them more the exact health care they need. So finally, family should be involved. Not only you know the information, you know the community, but the family should be involved in the care you want to give them. So because with the family, you can have a better screening for this population. Let's say you have a population in Brooklyn, all those, the area, all the people, they come with caries in the dental. So you know what to do at that point. All the patients, they come with the same type of disease. You know what kind you have to screen in this population. We know also what you can prioritize from resources, what intervention you have to. So when you know the families, so you can do better for this population. So there's the website for the family. They have some of this National Institute Children's Health Quality you can go, and they work with Johnson Foundation. They have also a website where you can go also and have more information also. So in summary, so to diagnose disparities in one's community and practice, you have to review the population data, you have to examine your performance in this situation, and also you have to know the family also. So the second part of the article, they talk about how to diagnose disparity in clinical encounters and innovate new practice models. So how can you know the patient has problem in this one? So what they said, the Maternal and Child Health Bureau said, when a patient comes to you, it's not the patient only. It's a whole person, whole family behind, a whole community systems approach, not only the kid only, what happened behind it. So they said also, you have to know what is upstream social determinants. And for this one, you can go to the next picture. So when I saw this, I didn't know what does that mean upstream. I didn't know, it's the first time I saw this one. What will you do for this girl? When you look at this picture, what will you do for this girl coming with diarrhea, abdominal pain? What will you do for this girl to treat this girl?
Just give for the hydration and then the antibiotics if it's a bacterial cause. Yeah.
And you, what you do?
Usually we do the same, but in this picture, I think you're showing that the water that she's treating is from the hand pump, and that is polluted. Like
so what will you do to treat that?
We
we talk about system, not only the kids. What will you do? So what happens? You have the kids coming for diarrhea. You treat this kids today, so the sister will come with the same problem. The other brother, the other will come for the problem. So this is a downstream problem. So the upstream is here. So you have this one infecting the water, and this is the upstream problem. So you have, once you resolve this upstream problem, so the downstream problem will be resolved. So you will treat really your population. So this is why they want to teach us now. Not only to take this kid coming to you, you treat the kid, but what is behind this kid. So when you, you can have an industry polluting water. So you have the same, you have the lead coming and the baby come for lead poisoning. What is this? You treat the baby, we send the baby home, another kids will come for the same problem. So we have to know the upstream, we have to treat the upstream, and so the downstream will be better.
So really you can just say look for the root cause.
Yes.
Yeah.
So not only look at the baby and you treat and you send home, no, what happened behind this is a wide system now. So the maternal and child, so we can continue. So for the diagnosis disparity encounters, they advise us to use there's four approaches. So they said the diagnosis and disparity by universal screening and connecting families to resources, we will go over that. Enhancing the comprehensive of services to address social determinants and addressing family health in pediatric encounters, and also moving care outside of the office into the community, home, school, and daycare. So this is the clinical approach they said. When the kid comes to you, you have the kid and the family, you have to assess both of them. And when you finish with this one, you go to what they call the medical home now. The medical home there, they put the person here, and you see they treat the person. But what the help you give all this person will be around. We have the social worker helping, you have the nutritionist will be there, you have the insurance if that's where you can do medical everything. This is what we put. And now we see the patient in the community, the care, the school, everything, what happened in this area with the patient. This is the clinic, the system they want to implement now. So the first approach to diagnose disparity through universal screening for new health vital signs. So what happened? The American Academy of Pediatrics on equity said we have to address not only the clinical problem, but the social, economic, educational, environmental, and personal problem for the patient. So if you look at the next one, so when the patient comes at the clinic, what will you do? We ask for the temperature, blood pressure, respiratory rate, heart rate, and growth parameters. That's it. We're done. But what he said now, we have the new health vital signs. We have to take care. This one with the root causes, as you said, of health disparity. We have to know the family employment, educational progress, the food, what the patient can have for feeding. What is the health? Does the person know how to read anything? How is the safety in the area? And also, what is is it any housing problem? So Robert Wood Johnson Foundation had those to help us have a better environment for this one. As an example, let's say you have a patient with asthma coming to see you. This patient comes for asthma, and this patient is living in a house with cockroach, everything like this. You just give your treatment in the ER, come on the floor, spend 3-4 days, and you send home. What happened? 1 month after that, he come back again for the same problem. So what we do now, you have to know to put the patient with the social worker that will go to the house, and now we'll take care of this problem of cockroach. At that time, you treat the patient not only with the asthma, but what causes the asthma all the time. This is the approach they want to do with the medicine now. So, now what can you use as material to help them? We have the WeCare 10-item family psychosocial screening. There are many tools. I can list them for you. You can go and read them. The WeCare 10, the other is very long. We have the smoke-free gov, and then the next one. You can go. You have the cap for kids. They are very interesting website. Also, when you go over them, you have all the information you need to give to the family. And the next one, the National Health Leads Program, you have this one also.
I think the cap for kids, you have to be a member.
No,
you have to pay a fee. No,
I open it. I have it here. I open it. I went. I play with it. It's very interesting. But they send an email to me after I don't have to use the material. But I open it.
I think you
Yes, you have to remember. But I open it. I read it. It's very interesting. And the next one you have also. You have all those. We can go. You have also all the systems they have here. You can use all the system they put. You can use to help you during with the patient. They said all the system, you have to be able to put the social worker with you, the nutrition and lactation system, educator, substance counselor, etc. will help you to teach better. The Reach Out of and Read Family Literacy is a good program also that help you with the kids. When they, I think from 6 months to 5 years of age, you can use it. You give one, every time the patient comes, you give one book and you teach the mother the family how to read for the kids. And they said in the school after that they have a better results in vocabulary than any other kids. So it's a good program that you have, many programs that you can teach the parents when you come to you at the clinic. So, and also they need also medical legal partnership. They need also public benefit housing. And you have to go and take care of everything with the patient when they come to you. So another approach is there's the AAP. They have also the families of the most central and enduring influence in children's life. So they want you to take care of the family too, not only the kids, but also the family. And the AAP will come on screening for parental smoking, because when you come and smoke at home, you have the issue with the asthma. If you have to look for any violence at home, and you have to improve the health of the family also. And then and they say, even though they told you even before pregnancy you can take care of, before the baby is born, what happened? Your pediatrician will take care of the kids. But at 12, 13, 14, they become adolescent and they will have baby at that time. It's a good time now to start teaching them and talk to them for the future. It's why they said you have to, from the prenatal intervention, you can do that on them and help them. If they have any disease, you can start giving treatment. If there are any problem, you can explain to them what will happen in the future. This is very interesting when you have those kids and help them improve. If they are taking drugs, you can help them. Everything is there from you as a pediatrician when you see them at the clinic. Adolescent medicine, not only just to test them, you send them home, but if you're taking drugs, you have to teach them. You have to educate them at that time, so in the future, you have a better environment for the kids who's coming. And the last approach, what they said now, you have to move outside the office. So you leave your clinic, you leave now you have to go to the community where the child is. At home, daycare, or at school. And they said also, you have, when you do all those, you will prevent all readmission in the hospital, and the quality are better, and the hospital will spend less money on those kids coming back and forth like this. So health reform as augmented home visitation program. That's good. We went today, that was a good one. Integration with the medical home could reduce duplication of services and fragmentation of work. So what happened with this time, what they said, and we went to the patient to see the patient today, when we asked the patient, what will you do when you have a baby? She said, I don't want to breastfeed. So we just explained to her what are the benefits of the breastfeed. Before we leave, she said, I will think about that now. Because I will have pain. So you never try. How can you do you have pain? So when you go to the family, you can explain to them, and when they come to the hospital, it will be easier for the medical staff to explain to them what is better. So in the school also, you have to take care. You will know exactly what is the harmonization. You can even start with what we do with the education for the feeding, for the obesity we have there. When you go and explain to them about the diet, they told you, yes, I talked to my mother about the vegetable, about the water. So at school you start already to teach them. So when we decrease the obesity that can come later on in life. So this is it I have to talk about. But after that, this is a website you can go over it. Now, she can go over the other parts. Thank you.
Thank you, Arnauld.
You're welcome.
Is that you? It's you.
Good afternoon, everyone. My name is Rapheisha, and I'm going to be covering the different tools that you can use to, and approaches you can use to make yourself more culturally sensitive to your patients and understand where your patients come from, their background. So,
Introduce your role here.
Oh.
Many people don't know.
My name is Rapheisha, and I am a patient care coordinator here, and I work with the families to enroll them into the exercise program, follow them. I also work as a facilitator for one of our new workshops that we have. It's called Path Apprentice Teachers and Healers, where we have a 6-week workshop with families that are in our program, and we teach them nutrition education, medical information on obesity, as well as fitness and the mental health aspect of obesity, things that the parents should take away and help their kids and talk to their kids about that they normally would not speak about. So for this part, the first one we talked about is becoming literate on health literacy. So what is health literacy? So health literacy is the ability for an individual to have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. So to think about health literacy is understanding what a doctor tells you and be able to comprehend and know how you can make appropriate health decisions. So health literacy is not determined by education level. Someone who has a high education level can still not be health literate. So that's something as a clinician to take away, that health literacy is very important. Studies have shown that it's also a strong predictor of health as opposed to looking at race and ethnicity, income, any social economic status in comparison. So we have one of the health kits that's used to promote health literacy. It was designed to simplify communications with confirming comprehension for all patients to reduce the amount of misunderstandings and miscommunications that may occur in the clinic. The second is to make the office environment and healthcare system easier to navigate. As we know, the healthcare system currently is very difficult, and it's not easy for persons who are not familiar with the healthcare system to navigate to get care. The third portion is to support patients' efforts to improve their health. So be like a counselor guiding them. In the toolkit, they focus on 4 primary areas. So verbal communication is one, written communication, self-management and empowerment, and supportive systems. The recommendation that the article had was to slow down. When you speak to the patient, speak slowly, don't rush through. Take your time. I know you have time limits sometimes, but try to be patient with the person and how they're understanding. Avoid using medical jargon. So once again, goes back to health literacy. Someone who is not familiar with medical terminology would not understand what you're saying. So break it down into layman's terms so that they can understand what you're saying to them. And using the teach-back technique. So teach-back technique is having the patient regurgitate the information that you give to them. So at the end of the session, you would ask them, we've discussed a lot of information today. So from what I've told you today, please tell me in your own words what you gathered from this. This way they don't feel like you're targeting them or telling them that they don't know what they're doing, but they also feel that now you want to make sure you're doing your job.
And that's the number one thing which is in health literacy. We did like 4 journal clubs on this last year on just health literacy. I don't know if you were there, but you know, we did that. And in that, the number one is teach-back technique, and using that is very, very powerful. They put it at one of the highest levels of healthcare literacy, because even if you're talking to a patient who's passed out, you know, syncope who's come and passed out, and you're giving them all these conservative management and instructions, they may not be listening, they may be texting, they may be looking here. So you just put it down and say, could you repeat everything, what I said? And you'll wait and see. Most of the times they'll forget most of it, not part of it. And then again you say, you know, let's repeat what do we have to do. If you feel dizzy, what are you going to do? If you feel this, when you're going to call the doctor. And that's what also is done for when you miss your medications. They're supposed to bring it out. That's called the brown box. I mean the brown bag. They take all the medications, they put it on the table, and then they go over everything with you. So they're supposed to bring their medications with them and then teach back. I mean, say, okay, I've been taking this in the morning, I'm sure you're taking this in the afternoon. Most of the times, the biggest errors are for medications. And if they can't teach back, especially for adults and even for kids, if they can't tell you back what medication is used to when, they always come without their medication. So that's another thing that you have to tell them to bring their medications back.
It's very important to teach back, as Dr. Drupa stated, teach back technique is very important because it shows also engagement. It builds that connection with your patient. So it's not just like a lecture, someone just comes to tell me what to do, but now you're engaged, now you can have a conversation that may lead to, as Dr. Arnauld pointed out, more conversation about their social norms, what's going on at home, as opposed to a one-time visit and they never come back. The other part is the delving into your unconscious bias. So there's a test, the implication association test, and it's used to detect unconscious bias on a variety of characteristics such as income, education level, race, ethnicity, gender, weight. Weight bias is a big one. The study found that unconscious preferences and stereotypes are not unusual. So it is very common for us to have stereotypes. We all have stereotypes. Regardless of where we acknowledge it or not, we do. The literature also revealed that there's an association between the clinician's race and ethnicity implication association test results and their patient care decisions. So there is an association of how the clinician treats their patient according to their perceptions. So some of the recommendations are to look at yourself and understand what your biases are. If you can acknowledge your bias, then you're able to better deal with it and know when you have the ability to affect behavior and treatment on your patients. So it's very important for, as a clinician or anyone in the health field, to understand what are your biases and how you can address them. So to ensure a culture of equity in the workplace, the American Academy of Pediatrics defined culturally effective care as the delivery of care within the context of appropriate physician knowledge, understanding, and appreciation of cultural distinctions leading to optimal health outcomes. The AAP, they created a culturally effective toolkit where these are recommendations of the toolkit, and it teaches you how to do these things. So staff should be aware of the diversity of the patient population. So know what you're serving, what your community looks like. If you're in Bushwick, you know the majority of your patients are going to be Hispanic. If you're in this demographic, in the Brownsville, Crown Heights region, you're going to see more of a Caribbean, African American population. The second is to inform community and be informed with community resources that are available for the population that they are serving. So as Dr. Arnauld stated in the earlier portion of the presentation, to link to the clinician should have information on community resources. You cannot connect families to resources if you don't know what those resources are. So another issue is informing, getting information, knowing what resources are needed. One of the article talked about a community where oral hygiene was the issue. So having a lot of oral hygiene issues, the doctor realized that what was going on was persons in the community did not have Medicaid for those, the dentists in the area did not take Medicaid. So what they did was they found places that did take Medicaid for the dentists and then gave them, the patients, that information. The next one is to inquire about non-traditional treatment. So treatments that culturally that persons may use that is not something that you may have used in your own treatment. So think about, inquire about them, ask the patient, what do they normally do if they get sick, or get an idea of what they do. Consider group visits for a family with limited English proficiency. So language barrier is a big one. Understanding that language barrier can affect health literacy, it can help affect the outcome of how the patient visit goes. And prepare for longer visits with patients requiring interpreters. So just in your mindset, understand if a patient needs someone to interpret the conversation, it will be a longer visit. So being an advocate. So health disparities are rooted in the social and environmental conditions outside of the healthcare system. So our environment in total is it's not equal. It does not have a lot of health equity for many persons, especially those who are low income, those of minorities. Clinicians should become advocates for health equity in the healthcare system, and medical associations, community organizations, and the American Academy of Pediatrics can help to power in that change. So in summary, the social ecological model, which was the model Dr. Arnauld showed earlier, it shows the interrelations between the individual person, and how it affects it to the community, their family life, and in long-term policy as well. The clinicians play a critical role in diagnosing, addressing, and eliminating the conditions that cause health disparities, and the evidence-based practices can guide improvements in healthcare. So those practices are the toolkits that we spoke about, talking about understanding the disparities that occur within your community population, knowing how to comprehensively give care, as well as going out into the community to do clinics.
So I think now we should open it up for questions, and then I have a couple of comments to make. Anybody has any comments or questions or experiences or?
Just one question about that teach back technique. So should we also use that?
Yeah, I mean they're giving you a toolkit, okay, to use. We did health literacy before, and all this is so they're just telling you where medicine is going into. Medicine is going away from just being traditional medicine, like he's given you example. You have to figure out how you're going to change and with your patient on a day-to-day basis. When I'm doing cardiology, it's different. When I'm doing obesity, it's different. When I'm doing primary care, it's different, right? So it depends on which patient we have and what is their acute problem. So you have to, if your patient is not understanding, if I'm giving 10 heart failure medications, I will use the teach back technique. If I'm teaching new nutrition concepts, I can use the teach back technique. What do you want to say? What are you going to make changes? It's also like goal setting at the same time plus teach back technique. So they're just giving you different tools and different thinking out of the box. This is where healthcare is going. This is where affordable healthcare is. I just went yesterday to meet someone, and they talked about basically another $1 million grant coming up just for the Brownsville group, where they're talking about this integrated healthcare system, and basically Brookdale wants to work with BMS, and BMS wants to work with Memority. So it's basically integrating health, and that's another way of treating healthcare disparities, because you may see a primary care patient in a location like your clinic, and after that patient needs, say, cardiology care, or he needs a GI, or he needs mental health. Then how do you connect the dots? How do you refer the patient? Is that referral followed through? Is there a patient navigator? That's what we're talking about. Is the person able to understand the healthcare system? That's all health disparities. Because if you have someone in Columbia or Mount Sinai who is on the Upper East Side, who's got enough funding and understanding, they will check this out. They'll check who's the best surgeon, they'll check who's the best doctor for them, they'll check this. Our patients can't do that. So we have to be advocates for them. So that's what they're talking about. So that's not only one thing, it's so many things there which you can adapt to this model. Any other comments? Dr. Panza, about mental health, I think we have Dr. Panza here in our system, and that's really, I would say, that's changed the way we treated our patients. 5 years ago, 4 years ago, we didn't do any mental health evaluations. And I think that's a big change of how we ourselves, we created our own 6-question screening. We screen every child who comes from mental health issues. We find 50% have mental health issues, whether it's depression, whether it's weight bias. So I think that's a new way of talking about, we approach healthcare disparities like that. We didn't have nutrition. We have a full, nutrition. Then we got a person, if our nutritionist feels that she needs someone more culturally sensitive, then she'll get a chef. And we got another chef who does their sort of food. So that's all going into healthcare disparities. So we have a chef now because they can talk about cooking. So these are all how we address healthcare disparities. Yeah.
I think
think you bring up a really good point, you know, that you have to incorporate not just the medical providers, but everybody that has different skill sets, that has different types of expertise, not only in the professional level, but also in the community level. Like, you know, I think something that they mentioned in the article is that they hire people from the community to be, you know, a representation for the patients to come in and have a familiar face. Sometimes they won't open up for their own biases, not only the provider's bias, but the patients might also have bias. So I think, you know, you brought up a really good point. There's different types of partnerships that need to be built, not only in the professional, but in the community, and also expanding into other health networks, you know, in order to be able to, you know, address the different health inequities that the patient might face.
And the whole issue now is that who's going to pay for this, because it's a real need. You know, you need community health workers. There's a new model about having community health workers in hospitals, where the community health workers, like you said, come from the community, they understand the community, and they liaison with the community and resources. But it's all grant funded at this point. It has to sort of be part of regular care. I mean, they're still paying more for a renal transplant than they're going to pay for community care. So, you know, every 4-5 years our healthcare system changes, even though they understand. I think the good part is the last 3-4 years they're talking this language, but we're not really there right now.
It's not immediate gratification, so it takes a longer time to even get funded.
Yeah, and that's the thing. I mean, if we didn't have the grant, how could we do all this? We can't do all this. So that means you have a health inequity is basically based on what you have, what monies you can get to the community. The other two things I wanted to tell you about, you can go to our Brookdale website, because Arnauld was talking about doing family assessments, and they do it, and we are due for our next assessment this year. So it's called the Community Service Plan. So every hospital now has to, who's funded by Medicaid, has to do a community service plan. The last community, and it's based on an assessment. So they basically go out and do assessments of health requirements, needs for about thousands of patients in the community. Then based on that, they make priorities of healthcare priorities. So you could go, if you ever have time, or we can do it one journal club, what is our Brookdale's Health Community Service Plan? And then what are their priorities, how they did the community assessment. So that could be a journal club. So you know your own community. This is all great, but you know, you have to still know your own community. So if you go into those websites and you get lost looking at some other community, when you have everything here. So you go onto your website and you have your community service plan, and the community service plan chose obesity as #1 priority, and second they chose HIV. So we are like very integrated into the community service plan. All the deliverables are done by Live Life, Live Right with Brookdale. So we are doing that. Now it's time to do the next community service plan. Hopefully maybe it will be mental health, maybe it will be something else. I don't know if we still have the TLC. So this year we all need to, you know, make maybe child health care, maybe infant mortality, I don't know. But it has to be done every 4 years. So you assess the community on their health priorities, what they want, and then you make your priority. You choose 2 out of 6 priorities. So there's 6 priorities. And then the last thing I wanted to do in the same art journal is this article, which is really, really so important. Because if someone has to ask you in one nutshell, how would you change health disparities? It's by bringing humanism back to the bedside. Really, if you can speak in a humanistic way, if you can speak in a kind way, doesn't matter what language you speak. Even if you can't speak Spanish, but if your reflection is like, I want to understand you, you can, even if it's sign language, you know, people are happy. People are ready to wait. And I've seen that. And if you show you're hurried and worried and you're worried about everything else, they feel that. So the stress of the physician goes on to the stress of the patient. So this is a very good article, and it's basically just 2 pages from this, and it came out from the Excellence in Medical Students Education in Pediatrics, and this is by the Arnauld Gold Foundation. And what they did is that it started from a symposium in 1996, where they wrote about barriers for sustaining humanism in medicine. And this program was approved, and it was so important that they basically made it a traveling fellowship program. Okay, and every year in October they have a program, I think at Columbia, where they do this couple of articles on humanism. And sometimes, you know, I just took some definitions, because as we keep on trying to find everything else, we really have to look inside. And if we can look inside and see what we learn on a day-to-day basis with our patients, that's most gratifying actually, and the help you can give. So what if they define is, humanism is a way of being defined by the characteristics of empathy, altruism and compassion. Now many times I didn't know the difference between pity and compassion. Many times we feel pity for our patients. Pity is something like you want to get rid of your own guilt. You know, you see patients who are sick, really. And I went and looked into the definition and found, they said sometimes your pity, oh, this poor child, he's suffering. Oh, you know, he's got heart failure, he's got this. And you just want to get him good so that you can feel good when you go home, and when you see your kids, you don't have to feel worried about them. Well, compassion is something that you actually feel that empathy with them, and you feel one with them at that point, and you're able to feel their pain without taking away your pain. It's not only about your pain which you're trying to take away, you're really trying to take away their pain. So that's what humanism is, like trying to take away the person's pain by becoming one with them and understanding their culture. While pity is trying to take away your pain because it hurts you. So that's a big difference between humanism and that. Then they said, doctors who practice humanism, clinicians have better outcome and increased satisfaction among patients. They also go on to saying, today's healthcare environment poses challenges to practicing humanism. Why? Because we've had medical technology, documentation demands, increased emphasis on clinical productivity, business aspects of medicine, and this has completely distanced patients away, physicians away from patients. It's just another number. Either it's a number to build in private practice, or it's a number to give the report in hospital-based practice. How many patients you saw, how many patients you saw. And we feel that big disconnect between the clinicians and the management. Most people in the management want us to just talk about numbers. If you bring anything about humanism to them, they think you're crazy, or they just don't think you're business-oriented. And the doctor has to be business-oriented today. So how do we make business? How do we make humanism our business? Because that's why we're all in medicine, for humanism. And also be productive. We're not saying we don't want to make money for the system, because we'll be out. So you can be productive and humanistic. So they give the characteristics of humanism, the attitudes, what you can adopt. And they say it can be taught. That's why I'm saying this. It's not something you just have you can teach it to the residents, you can teach it to the medical students. And they say the attitudes of humanism include humility, number 1, curiosity, number 2. You're curious about your patients, you're curious about their background. You can't be forced to know about their background. Sometimes, long time ago, when we had some residents in, obesity clinic, they used to do like this. When I used to be talking to the patients sometime, and then they used to, can I go? They used to be looking at their watch. Now it's changed. You'll see over time this changed. They want to stay. Once someone told me, I don't even want to mention, how could you do this? How do you spend so much time talking to these patients? Don't you see that they're not interested and all that? So, this is 5 years ago, because it was only intubating patients, doing something, getting them out of the ICU. So, humility, curiosity, desire yourself to maintain a high standard of behavior and role modeling, your own. Only then the other people, residents can learn. Including self-reflection. How many physicians go home and reflect on what I saw today? Who I attended today? What made the day today? What made it good today? What made it bad today? It's self-reflection after you go home. And seeking connections with patients. A focus on personal resilience and wellness. How many of us think about our personal resilience and wellness? How many of us feel that we have to be well, we have to be healthy, we have to exercise, we have to eat right, we have to sleep right, we have to think right before we come to our patients? Because if we are not thinking right, if we are not sleeping right, if we are not eating right, we bring that negativity to our patients. You may be irritated because your spouse was irritated in the morning. And you bring that home here and you say that, oh, just get this patient over to me. And that's another part of humanism, is not to bring that negativity in. And we all do it all the time. We didn't get a good score. Our abstracts got rejected. We are in a bad mood. And we bring it back to work. And I think we've all done it over the last 20 years. That's why they're bringing it here. And then if you bring this down, the clinical practice recommendations, okay, and it just if you can read this, it brings all this health disparities back into practice. How do you bring it? Because I'm a practical person, the people who learn with us. And our program is like that. Whatever we learn in the textbook, it has to be applicable. Otherwise, it's useless. Knowledge is useless unless it's applicable. So all this information we get, we bring it back to our bedside. So for example, strategies embedded during patient care activities encourage learners to incorporate humanism into personal learning goals and individual learning plans. Like, for example, I want to explore and address the fears expressed by the parents I see. You know, they may be having a fear of obesity, but we got so used to it and we're not even talking about it to them. Are you fearful about the problem? Are you worried about the problem? It's like, you know, immediately we want to tell them what our worries are. We are worried that you'll get diabetes. We are worried that you'll get hypertension. What is their fear? That is one way of saying it. The other thing is parents' perspective. What do you think is the patient's most important current priority? Is his priority making a change in nutrition, diet, or is it something else? You know, we don't even care about their priority. Maybe they've come in just to fulfill an obligation of a referral. Maybe they've come in just to get an immunization. Maybe they've come in not to listen to you, you know, about mental health. So what is their priority today? Can you change it or can it be a next time thing? And then they say heighten the learners regardless of the parents' impact of illness. Maybe you've seen a chronic patient. Maybe the patient is in renal failure. What is the impact on the whole family? You know, again, like he said, not only on the individual, is the mother having to leave her job? Is the father able to support the family? Is the grandmother at home? You know, just having 2 minutes, it says 2 minutes to practice humanism. They've given the time. It's just a question about who else is in the family, who else is, already you've connected to the health disparities, because you know it's not a disparity, it's a connection actually, so you're making. And one thing they said, which I don't do much and I should do, we all refer to most people by mom and dad. They say try to ask the name, and I think it's very important. Dr. Panza always says, please write the parent's name on that. And as to wonder why he always insists on that. It's very important to get the name of the person. I don't even know anybody's name, and you know, I learned that I have to use names. Sometimes when they come into the room, it's just a hi mom, how is that? It's like impersonal again. And or just ask the parent, how would you like to be addressed? That itself bridges the thing. Do you like to be addressed by mom, or do you like to be addressed by Mrs. Smith? How should I address you? That itself makes the connection. Sometimes they'll say, it's fine, you just call me mom, that's fine. We can't also assume that they want to be called by their name. You see? That is also thing. So those things they're saying. And reflect on the action. So for example, what they mean when we see a patient in our office, right? And we're talking, a lot of us are doing teaching at the same time. So we have 3-4 residents, we have students, even while we're discussing obesity. So this is part of the motivational interviewing thing also, but it's taking it out more into humanistic touch. So a patient comes and he's talking about something, reflect on it. So like she's saying, you know, yesterday we went to KFC and we ate a lot of chicken, but it was his birthday, and we're trying to just blow it off, and we're trying to say that, you know what, oh, you shouldn't have eaten that chicken. Oh, it was a birthday. Oh, no wonder you maybe have eaten. You know, reflect on that action. Make it a positive action for them rather than a negative action. And even when the residents are presenting the case, you know, they say present the case like you're presenting, sitting next to the patient, include him in the presentation. That's what they don't do a lot of times. So this is a 10-year-old boy who's come to you for a history of a heart murmur, or he came to you for syncope, or he came to you, they'll just keep it on he. So this is John. He's 10 years old, right, John? You know, I'm going to tell the doctor about you. John, you're 10 years old, you passed out twice. Remember you told me, now when you passed out, the first episode was when you were school. Keep looking at the patient, keep including him in the conversation, not like, patient is 10 years old, came in for a history of syncope, never had any history, past medical history was negative, family history is negative, and like that. And sometimes the resident doesn't even bring the patient in. They're telling me that about the patient when the patient is in the other room. I said, no, bring the patient into my room. You really want the patient in? I said, yeah, he's the patient. and then most of the families like it, because they like to be included, and then they like the teaching, and then they write the writing, and they say, oh, we learned something. So include them in that, and if it's and say, if you have any question, family member, you could ask. And sometimes they say, oh, now I learned a lot because you're explaining to the resident. So this is all about humanism in the end, and they say identifying perspectives of the patient, exactly what you talked about. but just doing it in a humanistic form, not in only health disparities. The word disparity means you're distinguishing yourself away, and humanism is bringing them towards. And reflecting on how these perspectives converge or conflict. You know, do they converge together or they conflict? Choosing to act altruistically, always for the patient, you know. Even if you've had a bad day, even if you have a busy day, you know, even apologize if you've got a headache or something to them. And endorsing the understanding of the family. So that's basically, this article I'll also send to you so you can have it with the other two, this article. And I think it was a great presentation in the sense that we all learned a lot of what we have to do. So thank you all for attending. Any more questions? Any experiences?
Dr. Dupar, when you describe about the medical home, would the resource guide that we were discussing other day will help the resident as well as the clinicians if they have it on their computer, and because lots of resources, free resources are available, and if they know directly in the primary care office, they can look at the resources, maps, and they can directly give it to the patient, print it out.
So yes, so Dr. Barros, you've been working on the medical home. You want to say something about that?
So, you know, it's nice that you brought that up, because there are so many wonderful programs, so many wonderful resources outside Brookdale that, you know, to really complement in what we do. I think that through the community pediatrics, that is the goal, for us to go outside, learn about those resources. So slowly we're creating a booklet of all the programs that are running in the community at this point. We do have emails that we send to all the attendings and all the residents with regards to programs that are running currently. I'm not sure how many residents or how many attendings are reading it. The idea of doing those emails is with the pamphlets, so they can, you know, have like a community board in there, you know, in their clinic. So if the mother asks for something, they can always, you know, go back and you know, get for the pamphlet and make a photocopy for the mother. I think we all need to take a responsibility on this. I think we all need to understand that we all need to cross that bridge, and it's not only part of the social worker or this one or the nurse or that one will do it. We as clinicians have the responsibility to learn about the community that we serve, to learn the culture of the community, and to learn what programs are out there, so I can have them in my hand and know what to do the next time a patient comes with a question or a problem. Oh, I have that program that I read about it, that I think it's a great match. The programs and resources that are going in the community, they changed. So even if we have something that last year was running, it may not be running this year. So that's why we need that constant connection. And once you connect with one program and you start referring patients and you have that connection with that program in the community, that flow will come, and they will come and they will tell you, we have a new program for this, we have a new program for that. So we need to keep that connection alive all the time. Just having a website, it may work today, next year it may not work anymore. And a lot of these programs, as Dr. Dupa was saying, they're all grant programs. And the money may run out at one point and may not have the funding, and the program, even though it was excellent, may not run again next year. So I think it's as, you know, as clinicians, we have the responsibility, and I'm, you know, so happy that Dr. Tupper distributed this article. I think it's so important, and I think this article is kind of the basic of what we want to do with the community rotation. And I know a lot of 30 years have been complaining a lot about the community rotation, and I really hope that, you know, after this presentation, you know, some of you that are younger in your residency kind of get why we want to do this. And becoming a good pediatrician doesn't mean knowing how to intubate and how to put an IV. Becoming a good pediatrician is way more than that. It's knowing that it doesn't matter if I know how to prescribe an antibiotic or if I know the exact antibiotic that I have to prescribe. I also need to understand, if the family understood what is this antibiotic for, what is this going to help, and if the family is going to go and buy it.
Right.
Right.
So it's understanding more into, you know, the culture of the community. And I think that also one of the things that I want you to understand is in terms of health disparity, is understanding that by living in a certain area, you have much higher risk of developing certain diseases as a baby than living in another zip code area, just by living in that area. And it's so important because where Brookdale is, it's an area where we're number one in a lot of things that we don't want to be number one. So, so I think that it is great that you brought it up, and but it's our responsibilities as clinicians. It's our responsibility knowing the resources and working as a team and not just refer patients. I mean, okay, yeah, the social worker will call him.
There's no social worker around.
No, there is not.
Yeah.
But I mean, you know,
even
when
if
they
there
brought
was, but there is no also. So you have to be the social
yes.
worker.
Well, so when they brought it up that, you know, there are programs that to bring social workers, that to bring
Right.
people to, you know, allies the community, it's also our responsibility.
Yeah,
It's not just,
Till
you
it
know.
becomes there, till it goes there, and we have more help, like Adriana was saying, like you have more so people who can help us in the community. Till then, whatever you can do, and sometimes you're very busy in the clinic, like Dr. Barros is saying, take that phone number and say, you know what, when I have a free minute, I'll call you back. You know, that means a lot for them. I'll call you back, or take an email, take a text, say I'll text you these resources because really I'm really busy right now. Those things. And then just keep it. You have so much free time, sometimes on call, sometimes post call. You're just sitting there, you can do that sometimes. And we have, I wanted to add to that we have volunteers who are going into the community. Introduce yourself.
My name is Victoria.
And she's from your college. And she does health education. Okay, so I have a volunteers program here. We call that the Let's Share volunteer program. We get volunteers from your college. They're very dedicated, and I'm sending them to the BFCCs. So one by one. So if you have any programs which you'd like to put on a community notice board, they need to create a notice board in every BFCC. Our resources, your resources, your resources, yours, mine, ours, Dr. Panza, your healthcare referral resources. Nobody knows where to refer for health services also, mental health services.
Yes.
So whatever resources we have, after you visited all the BFCCs once and you know them, then you should have a community board, a community resource board in every BFCC. We'll make the photocopies, get them from Dr. Barros, get them from us, and then have them put up in such a way, and then we can revisit every year.
And then also don't assume that because somebody knows about a program, everybody knows about it. Because even here at Brookdale, we have like a you know, home visiting program that I know everybody now is aware of it. When I just joined Brookdale, like I will say that 80% of the people had no idea that we had this program in here. In the same Brookdale Hospital. So don't assume that because you know about that program, everybody else knows about that program, because that is not the case. Okay, so we need to kind of communicate better. If you find any other programs that are there, share it between and look at the emails, print the things, put it in, show it to your attendings in the BFCC clinic. Says, you know what, I got this email. There is this Baby and Me group that is completely free. It's here and around the Brookdale area. Should I put it here? If we have a mommy, we can offer it to her.
And I think the community pediatric rotation is, and our rotation, what we do is, we do this journal club every week. It's not easy to do it. First you have to choose the right article, then you have to get the right person to do it every week. Before the week is over, I have to start thinking about the next article. No, and then we have to make sure it's done. But it's a commitment to learning, and that's what we all are here for. So in the BFCCs also, whoever is there in the rotation, you should bring up things like this. You should have afternoon journal clubs. You should have talks. It's not all going to happen in the offices. This is where you can go and look at the community notice board. You can see what's out there. You know, your attendings. You'll feel much better. You won't just say, oh, I've got 10 more patients today. I've got 15 more patients today. So is there anything like that in the BFCCs where they have learning? So
Well, one of the things that I also was thinking.
There is, but like one or two, like I know in New Lord's Clinic they do such things, but
And like Dr. Ashitino can help us with the adolescent, resources. We have a lot of adolescent girls who have GYN problems, and we really don't know the number where to send them, who to send them to, where to go, a lot of things.
So no, brought up issues. Let's say we have a patient 4 years old, and we didn't know the mother wanted this, and we didn't know where to send that patient. So bring it up and say, okay, so what, it has to be something that we can do to help these parents. And as Dr. Duper says, I'm going to take your number, mommy. I don't know right now,
but
from
I'll
the
find
top
out.
of my head, but let me find out if there's any program that can help you with your child. And then we can all look it up. You can come to my office and say, Dr. Barros, I have this. I get calls about resources almost every week. And sometimes they call me for things that I don't even know what to do. But I research. That's how I know all the resources available and what are the programs that will take what are the conditions of every program, and then we can all be part of this.
Okay? So thank you, Dr. Barros. Thank you, Dr. Astino. Thank you, Adriana, all the new people who came in. Thank you, Yash, for setting this up. Thank you.
Thank you.
Thank you, Arnauld.